Good morning, everyone. Thank you, Imogen. Well, first of all, thanks to Imogen for inviting me. Thanks to Imogen for inviting me 3 years on the trot, and this is the first time that I've been able to come here, and I'm really blown away by the organisation, the interest, and the number of people, and it's really impressive, and I think a testament to everybody's work that's gone on here. So well done. Final thanks to Imogen for giving me a topic that allows me to talk about anything that I'd like to, which is great. And so what I'm doing is to flag up a few things that I think will potentially influence how we look after patients with melanoma. And some of those topics will be addressed by my colleagues in more detail later on. So really I'm kind of flag waving and introducing some certain topics that colleagues will address later on in the session. I was interested by the conversation that James has just had with one of our patients here, and that's a real issue, and I'm going to go into the data about duration and decision-making about duration. I was interested to see that it's obviously at the forefront of everybody's minds. So this is what I'm planning on covering. The last 12 months, there are lots of changes, and you'll hear your doctors refer to many of these things. And what I'd like to do is just to introduce the issues that these are touching on. One of the questions in the MCQ was about staging, and there are some changes in the way we stage patients, and that has an impact potentially for our use of drugs to try and stop future relapse. So I'd like to explain to you what those changes mean. There are some changes in surgical practice, and I just want to introduce those to you. Talk about adjuvant treatment. I mentioned duration of treatment. Give you a little bit about a combination therapy for BRAF inhibitors, for BRAF mutant disease rather, using BRAF MEK inhibitors that hasn't had much exposure in the UK but is likely to have more. And also mention some mucosal melanoma guidelines that have been developed by Melanoma Focus. I'm a trustee of Melanoma Focus, and it's a fabulous charity that has developed guidelines where there have been none produced by NICE. And the mucosal guidelines have just recently been published. So I mentioned that some of my colleagues will be covering these areas in more detail later on, and there they are. So I'm not going to take their thunder, but I just hope that I'm going to give you a little introduction to make it a little bit easier. So staging, first of all. So people often, when they come to my clinic, they get a bit confused between what's a stage and what's a grade of cancer. And staging simply describes where the cancer has spread to. And the reason that we do it is it identifies groups of patients who are at similar levels of risk. Because when we're trying to run a trial or trying to assess benefits of an intervention, we need to be able to measure the benefit of the intervention in a group of patients, all of whom have got roughly the same level of risk. So it allows us to make comparisons between different drugs or different approaches between different trials, because we know that we're looking at patients with equivalent risk. So it's just a way of categorizing different risks of disease. And every cancer has its own staging system. And in melanoma, we use this AJCC, it's an American Joint Committee for Cancer Classification, AJCC staging. For melanoma, stages 1 and 2 refer to the primary lesion. Stage 3 is locoregional disease, like the N1 disease in the MCQ question we had. And locoregional disease could either be satellite lesions around where the tumour has started or spread to the nearest lymph nodes. And then stage 4 is where it's escaped beyond the nearest lymph nodes. Okay. And there's been this change I've mentioned from AJCC 7 to 8. And there is an implication potentially for how that might impact upon adjuvant treatment, which I'm going to touch on later. Now, what about surgery? So the main change with surgery that's happened over the last year or so is regarding sentinel lymph node biopsy and what we do with the result of a positive sentinel lymph node. So many of you, I'm sure, would have had primary melanoma removed, and at the time of the wider excision, had a procedure, the sentinel lymph node biopsy, which identified the nearest lymph node to see whether or not there was any cancer that had spread into that. And we know that historically, that information identifies patients who are at higher risk for relapse in the future. So if the disease has succeeded in spreading to the nearest lymph node, then there is a greater chance that it could also have spread away somewhere else. And so those patients are at higher risk of future relapse. So sentinel lymph node biopsy previously was a two-stage procedure. You'd identify the nearest, the surgeons, would identify the nearest sentinel lymph node, the nearest node, and that provided prognostic information. In other words, if there was cancer in that sentinel lymph node, there was a higher chance that the cancer could have spread somewhere else as well. Conversely, if there was no cancer in this sentinel lymph node, there was a lower chance that the cancer could have spread somewhere else. So that was the first stage. Then historically what happened is that if there was disease found in that sentinel lymph node, the surgeons would remove the remaining lymph nodes in that area. And the logic, which was understandable, the logic was if it had got to that first node, maybe it had got to some nearby lymph nodes as well. And that by removing those lymph nodes, if that was the only place that the melanoma had gone to, then patients could be cured by removing those remaining lymph nodes, assuming that it had not gone anywhere else. So highly logical. And so historically, what would happen is that sentinel lymph node biopsy would be done. If the node was positive, then the remaining lymph nodes in that area would be removed. And that operation is called a completion lymphadenectomy. And the idea of that was therapeutic intent. In other words, to try to stop further relapses in the future. Now, the thing that's changed over the last few months is that we've got data from 2 large clinical trials that, interestingly, have shown that if you look at the outcome in patients who've had a completion lymph node dissection and look at patients who did not have a completion lymph node dissection, there's no advantage. People don't live longer. Their chances of survival are not increased by removing those remaining lymph nodes. And so there's a change in surgical practice, which means that fewer and fewer completion lymph node dissections are going to be done. Now, Melanoma Focus arranged a meeting before their main meeting in Cambridge recently, the day before, where many surgeons and oncologists and patients as well attended to debate how this change in surgical practice should be translated. And there's a document that's in preparation at the moment, which will hopefully give a consensus opinion about how this information should instruct future surgical practice. So the new data is that completion lymphadenectomy does not improve overall survival. And I've said on there that it has morbidity. In other words, that it's got infection risks, you've got leg swelling, or lymphedema risk, whether it's leg or arm, so morbidity, problems caused by it. And you can't really justify the morbidity of that if there's no benefit in overall survival. The second issue here is that sentinel lymph node biopsy now identifies a group of patients who may benefit from adjuvant therapy. I'm going to explain what adjuvant therapy is in a minute. It's extra therapy to try and stop a relapse. And so probably what's going to happen is that the surgeons are going to be doing many more sentinel lymph nodes, not just to identify prognosis, but to identify patients who may benefit from extra treatment. But they'll be doing far fewer completion lymphadenectomies. So that's a major change in surgical practice. And it has implications for how we organize surgical melanoma specialists around the country and changes the balance of the operations that they'll be doing. So what about adjuvant treatment? And I know Matt Wheater's going to go into the details of this later on. And I'm not going to show you any data, but I just wanted to set the scene for what adjuvant treatment is, because this is a very major change for us all. So what is adjuvant treatment? So it's treatment after a potentially curative treatment, potentially definitive treatment, to try to reduce the risk of future relapse. So the definitive treatment is usually surgery, although you could have high-dose radiotherapy treatment of a tumour. And basically, adjuvant treatment, then what you're trying to do is, in case there are any microscopic cancer cells that have escaped away from the area that you've treated, you want to give an extra treatment to try and sterilise those and stop them causing a future relapse. So an adjuvant treatment is a treatment that attempts to eradicate or sterilise any microscopic residual disease that could cause a relapse later on. So this is commonly used in other cancers. So, it's about 1 in 40, 1 in 50 of the UK population who end up developing a melanoma. It's 1 in 8 women who develop a breast cancer. And so many of you will know women who've had a breast cancer, and very frequently they will have adjuvant treatment after the primary breast cancer is removed, either with hormone treatment or chemotherapy or radiation. And the idea of those things is to reduce the risk of microscopic disease surviving that can cause a problem in the future. So we've never had an active enough option in melanoma. There's a whole, 2 decades of work with interferon, again, the non-targeted treatment that was mentioned in the multiple choice questions, of interferon being used in the adjuvant setting at various doses. And the bottom line is that despite lots of intensive activity, it probably reduced overall survival, improved overall survival by about 3% at 5 years. And it was highly toxic, and therefore, in the UK, interestingly, and sensibly, it never became a standard of care outside a clinical trial. It was a standard of care in a few places around the world, particularly used in Italy a lot, but also in some centres in the US and in Australia. And people have backtracked from initial enthusiasm for interferon. And so that left us with no active options with melanoma. And what's happened in 2017, 2018 is that we've got positive trials in the adjuvant setting with all of the targeted drugs that you hear of. So many of you will be aware that for advanced disease, we've got 2 main groups of drugs for melanoma. We have immunotherapy using the checkpoint inhibitors, and those can be used in any flavour of skin melanoma. And then we have BRAF-directed therapy, which targets the cancers that contain a BRAF mutation, which is 40 to 50% of melanomas. And both of those types of treatment are very active in the advanced disease setting. The question here is, if you use them early on after somebody's had surgery, can you reduce the risk of a future recurrence? And as I say, over the last 12 months, we've now got data showing that there's a major benefit when you use these drugs in the adjuvant setting after somebody's had surgery for stage 3 disease. So what they show is approximately, depending on the trial, there's a 40 to 50% improvement in the risk of relapse. So this is a major change in practice. So people presenting with stage 3 disease, lymph node disease, whether that's microscopic or macroscopic, people who've had an operation and who previously would just be on a surveillance program, keeping a close eye on them for future recurrence. Now we're saying we've got data that can potentially reduce the chance of relapse by 40 to 50%. And that's obviously attractive for patients and their clinicians. And as I say, that data is with both the BRAF-targeted therapies and with immunotherapies. So the data was presented at ESMO last year. The Pembrolizumab data was published last month or the month before. And there was a licensing meeting at the European Medicines Agency that a few of us were at on Monday this week. And the mood music is positive. NICE are looking at the drugs in the summer. So I think the dabrafenib trametinib appraisal is on July the 19th, and the nivolumab appraisal is in August. And so if NICE approve those agents for use in the adjuvant setting, hopefully we'll be able to offer this routinely by the end of the year, which would be a major change. Now, that has huge implications for service capacity. So we at Mount Vernon get approximately 100 stage 3 patients a year referred to us. And outside a clinical trial, all of those patients will be followed up on a high-risk surveillance program. We actively monitor them with regular scans, and they come along to clinic. But effectively, what we're saying with this is that the majority of them will be offering extra treatment, and that might be tablet-based treatment with BRAF inhibitors, or it might be immunotherapy-based treatment with intravenous immunotherapy. But the implications for our service are huge, and the NHS really isn't very good at planning forward to cope with this rise in activity. So I don't know how we're going to cope, but we are going to cope. So I mentioned staging had a relevance to this, and I'm flagging it up to you because it's something that you might need to be aware of. And I'll just take you through the detail of it. So I mentioned that staging identifies patients at risk. Now, the adjuvant trials that I'm talking about were trials of BRAF-directed therapy with dabrafenib and trametinib, and trials with immunotherapy, either nivolumab or pembrolizumab. And when you look at the patients in each of those trials, the patient populations were slightly different. So in the dabrafenib and trametinib study, there was stage 3A, stage 3B, and stage 3C patients. In the nivolumab study, there was stage 3B, 3C, and resected stage 4, that subgroup of stage 4 patients whose disease has just been localized in one place and they have an operation to remove it. And then the pembrolizumab study had all of the stage 3 patients. So the reason I'm just flagging this is that a few of us have been wondering whether, when it comes not just to license but to a NICE decision about reimbursement, whether or not the authorities are going to restrict access to the population that was reflected in the clinical trial. In other words, for instance, will we be allowed to use nivolumab in the adjuvant setting for stage 3A patients when there were no stage 3A patients in the nivolumab study? Now, if you look at the evidence base, as I mentioned, there weren't stage 3A patients in nivolumab, and you can see the differences between the evidence base there. But the reality is there's absolutely no biological reason to think that there's any differences here. In other words, we've got adequate evidence for the use of these drugs in enough patients across enough range of disease to have confidence that nivolumab will be helpful in the adjuvant setting for stage 3A disease. We know pembrolizumab is, and microscopic disease is microscopic disease. There's no reason to think that the drug is going to have differing activities across different populations of risk. So there is no biological reason. So I'm just flagging this up to you because hopefully the reimbursement authorities will say, yes, you can use these drugs across all resected high-risk patients, all stage 3 patients and resected stage 4 patients. But if they limit it, it's not because the science justifies it. They'll be limiting it because they'd want to limit cost, and at that point it may be that there needs to be a bit of a activity on your part to try to do what you can to ensure access to drugs. Okay, I may be mentioning something that turns out not to be an issue, but we've had more than enough evidence in the past that sometimes there can be restrictions upon drug access that don't reflect the data, but that just reflect a combination of economics and politics. So that's what I wanted to mention about stage 3. Matt might go into this in some detail, so I'm wary about doing too much on this. But basically, with BRAF wild-type patients, people whose melanoma does not contain the BRAF mutation, we just have an immunotherapy option. But for patients whose disease contains the BRAF mutation, well, we've got evidence that BRAF-directed therapy is active, and we've also got evidence that immunotherapy is active, and the patients and their doctors will be making a choice between the two. Presumably you're going to go through this, so I'll move on. Okay. So the next thing I wanted to flag up was this issue about duration of treatment. And basically, I've got some data slides, which are the slides that James referred to, that hopefully will illustrate to you where we are with this data. So James mentioned this clinical trial, which was Keynote 006. Unfortunately, there weren't that many patients in the UK on this trial, but it was an important trial. And this was the design. So patients with advanced melanoma received pembrolizumab either fortnightly or every 3 weeks, and they were compared to ipilimumab. And this is quite an old trial now. And the issue about this update that Georgina Long presented a few weeks ago at ASCO was looking at the patients who received pembrolizumab, and there were 550 odd of them, and looking at those who had completed 2 years of treatment, because on this trial, the treatment period was 2 years, and then it was mandated that treatment stopped at 2 years. So the question is, what happened to those patients after they stopped treatment at 2 years? Now, obviously, that's a select group of patients. They are the patients who have done well. Patients whose disease started growing before that were excluded from this analysis because they had less than 2 years of treatment. So this is the focus on the patients who have done well, they've had 2 years of treatment, their disease has remained under control, and they've got out to that 2-year period. And what you can see is, using this imaging criteria that James mentioned, this RECIST thing, where we say, where we define scans as to whether patients have got any visible disease or not. So if there's nothing we can see anymore, they've had a complete response. They've had a partial response, the disease has shrunk significantly, but it hasn't gone entirely. And if there's stable disease, then the disease hasn't grown significantly. So we look at those 3 different groups. And if you look at outcomes, I'll tell you what, I'll pass these slides. Don't worry about photographs. The slides will be available. So.
All of the talks are filmed, so the slides will be available.
So yeah, so the slides will be available. So what I'm going to show you is the outcomes for those 3 different groups of patients. The first thing to say is that when you look at all of the patients together, so there are 100 patients who were treated out to 2 years. So out of those 550 odd patients treated with pembrolizumab, about 100 of them got out to 2 years. And this is the progression-free survival curve. So at the beginning of this curve is the 2-year time point. So this is what happens to those patients from 2 years going on. And you can see the line starts at 100. In other words, 100% of people have not progressed at that point. And then you can see at 1 year, 12 months, about 5% of patients have progressed. And then when you get out to about 18 months, the number drops down to 10 or 15% of patients progressing. But there are lots and lots of little dashes, which means that the curves are not very statistically robust at that far end of the curve. Now, the question is, what information does the quality of the response that patients had with pembrolizumab have on the likelihood of them doing well? In other words, whether somebody's had a complete response or a partial response or a stable disease at the 2-year time point. And so if you subdivide that curve into how people did at the 2-year time point, you can see that there's a difference between the patients who'd had a complete response and those who had a partial response and those who had stable disease. Now, the bottom line is if you had a complete response or a partial response, you had over a 90% chance of not progressing at that 18-month time point. Whereas if you only had stable disease, you've had a higher chance that the disease was going to reactivate when you stop treatment. Okay, so it feeds into this observation that it looks as if there are some patients who do well who may not need further treatment, but it would be nice to have 5-year follow-up on this rather than 18-month follow-up, and that'll be the clincher. Now, I've only got 10 minutes left, and there are a couple of important things that I wanted to share with you, so I'm going to move on a little bit. There was a little bit of data on the handful of patients who did progress and what happened to them when they were re-exposed to pembrolizumab. And this shows those 8 patients who had 2 years on pembrolizumab, then stopped, and then their disease started growing again, and then they were re-given pembrolizumab again. And you can see that many of them responded. So on the right-hand side, the dark blue bits, if I've got a laser here. So the dark blue bit is when they were re-challenged with pembrolizumab. And these triangles show that they've had either a response or stable disease. In other words, they've had clinical benefit. So you can see almost all of these patients, many of these patients, 1, 2, 3, 4, 5, 6 out of 8 patients had some evidence of benefit with a re-exposure of pembrolizumab. And that feeds into this problem that we have with NHS England at the moment, not allowing us to retreat patients in whom we've stopped a course of treatment with. So in terms of duration of PD-1 therapy, it looks as if 2 years is enough for the majority. And I've just shown you a bit of early evidence that you can recapture a response with retreating patients if there is evidence of progression. But our problem that's already been referred to is that NHS England is stopping us doing that. And I'd be, it's not often I'm a little bit more blunt than James, but I'm going to be a little bit more blunt than James, because at the moment what's happened is that Paul Lorigan, who's the chair of Melanoma Focus, has written on a professional's behalf to Peter Clark, asking for them to look at these rules, because we believe that with immunotherapy, the rules not allowing retreatment, the logic behind that is flawed, and you can't use the same logic as one would use with chemotherapy. But if the answer is negative, if they don't change their practice, I'd be really encouraging that there should be a major storm over that. It's perverse, because at the moment, I have patients who've had a complete response at 2 years. I think they probably don't need any more treatment, but I'm keeping them on treatment after having explicit discussion with them because of my nervousness that I'm not able to re-expose them to drug should they need it in the future. And obviously that's costing the NHS far more than these rules were designed to. So, so it goes against all common sense and all agendas, and because of the cost implications, I'd imagine that's very politically sensitive. Should a letter be written to a major newspaper, for instance? Okay. So the question is there any other data that can help us about identifying when we can safely stop patients on treatment or not? And the Sydney group presented some data at ASCO looking at the use of PET scans. So for those of you not in the know, a PET scan is a CT scan with an extra element to it. You get an injection of radioactive sugar, and the sugar is sucked into actively turning over cells, active cells, and the sugar's not like normal sugar. It gets stuck in the cell, and it's because it's radioactive. It glows on a scan, so it gives you some extra information about the activity of the cells. So the question is, does a PET scan give you extra information about how well patients do at the point where they've had a good response to PD-1 inhibitors? So what they did was they had a look at what they called a metabolic response, so complete metabolic response, partial metabolic response, stable metabolic response, progression. So that's the PET scan, and compared it to the data from the CT scan. And I'm sorry these curves are small, but this is seeing if that information helps you predict patients who are going to do well with immunotherapy. So they've had a year of a PD-1 inhibitor, then they've had a PET scan and a CT scan, and the question is, with information that the PET scan and CT scan has given, can you identify patients whose disease is going to reactivate again after that year of treatment or not? And what you can see is the top curves are progression in other words, low levels of progression, in people who had a metabolic response. So in other words, and the yellow scans are patients whose disease was assessed simply by CT scan. So if you've had a metabolic response, and a complete metabolic response, and you stop treatment at a year, you have a very good chance that your disease isn't going to reactivate. Whereas if you've had a CT response but not a metabolic response, there's a high chance that your disease will reactivate. In other words, if after a year of treatment you do a PET scan and the PET scan shows no activity, your chance of the disease reactivating is very low. Whereas if at that year of treatment you do a PET scan and there's still activity there, even if the lumps have shrunk, it's likely that the disease is going to reactivate. So perhaps we should think about using PET scans to make the decision about who we're going to stop treatment in, who have had a year or two of immunotherapy. Although I have to say, I wouldn't use that data as an excuse not to have the ability to retreat patients should they relapse in the future. But it's an interesting study. Okay, I'm going to whiz through this. I just wanted you to know about this encorafenib-binimetinib combination. So it's another BRAF inhibitor in combination with another MEK inhibitor. Many of you will be familiar with dabrafenib and trametinib. Encorafenib is another BRAF inhibitor like dabrafenib and like vemurafenib. And there was an update on this by Reinhard Duma on the Columbus trial. And this was a trial where this combination of encorafenib and binimetinib was compared against either vemurafenib, which was the standard BRAF inhibitor at the time, or compared against encorafenib alone. So in other words, two drugs versus either a single agent BRAF inhibitor there or a single agent BRAF inhibitor there. So when you look at this curve, you can see two drugs are better than one drug. So just like dabrafenib plus trametinib versus dabrafenib, just like vemurafenib, cobimetinib versus vemurafenib, two drugs, BRAF plus a MEK inhibitor, is better than one drug. So this is a comparison of two drugs, encorafenib and binimetinib versus vemurafenib. So it's not surprising that two drugs are better than one. What is a bit surprising is the 14.9-month progression-free survival. That's higher than we've seen with the other combinations of BRAF and MEK inhibitors before. And the question is that real, or is this just one of these cross-trial comparisons, meaning that this group of patients were going to do a little bit better? Now, within this trial, there was also this comparison of encorafenib on its own versus vemurafenib. And you can see that there's superiority of encorafenib versus vemurafenib. So this is just the BRAF inhibitors on their own. And previously, the BRAF inhibitors we've had, they differed in toxicity, but in terms of activity, they were exactly the same. They all had about a 7-month progression-free survival benefit. So vemurafenib and dabrafenib are about the same in terms of efficacy, although dabrafenib is better tolerated than vemurafenib. Encorafenib, compared to vemurafenib, looks better. So another couple of months. So it may be that this 14.9-month benefit with encorafenib and binimetinib is a bit better than what's currently out there. And again, there are appraisals going on for this combination. In terms of toxicities were pretty similar. In terms of toxicities were pretty similar across the board of what we've seen before with combinations. The interesting thing about this combination is that the toxicities tend to be things that patients are not so aware of. They tend to be laboratory abnormalities rather than fevers or skin rashes. So we'll see how that goes, but I think it would be good to have that as an option for the future for BRAF mutant disease. And then finally, and hopefully you'll leave 5 minutes for questions, I just wanted to flag, because I was tasked with talking about guidelines, that Melanoma Focus have just released guidelines on this rare subtype of melanoma. I mentioned that there are really data gaps or guidance gaps where when you're looking at niches of rare subtypes of melanoma, Melanoma Focus supported guideline development with eye melanoma that I was involved with, and that's been very helpful in changing practice for eye melanoma patients. And they've just done the same with mucosal melanoma. Remember, not all melanoma starts on the skin. Sometimes it can start internally, whether it's at the back of your nose or in your gastrointestinal or reproductive tracts. So the guideline is on the Melanoma Focus website. The link of it is there, and it's got information for clinicians, but also information for patients as well, and all the evidence reviews are there. So it's a cracking piece of work. So my final slide, in summary, surgery is changing. I think for the better. Less operations, fewer operations that are morbid that don't help patients, but more operations that identify patients who could benefit from extra treatment with adjuvant treatment. The data about duration we've kind of explored, and there are both clinical and commissioning issues there. And I've mentioned this alternative option for BRAF-directed therapy that hopefully we'll have access to in the not too distant future. Thank you.
Imogen said I have to carry the mic around.
Okay.
She doesn't want to.
Okay. Any questions?
Hello, thank you for that. I'm a stage 3 patient, and I asked my consultant recently about the adjuvant therapy, new options that might be coming up, and she said that would just be made available, if it is, to newly diagnosed patients, which would exclude me. Do you have any thoughts on that?
Yeah, I've got two thoughts. One is what's likely to happen, and the second is what should happen. So what's likely to happen is a reflection of the data sets we've got, because on those clinical trials, all of the patients on the trials started treatment within 12 weeks of their surgery. And so it's the license for the drugs hasn't been awarded yet, or in Europe, but it will be at some point. It's possible that they may mandate within 12 weeks of surgery on the license. But even if they don't, I'd be very surprised if the reimbursement authorities didn't mandate that treatment would be for a group of patients within 12 weeks of surgery. What I think should happen is a bit different from that, because when you look at relapse rates for stage 3 melanoma patients, obviously the chance of relapse changes depending on the burden of disease. So that's why there are differences in relapse rates between 3A, 3B and 3C. But the bottom line is that not everybody relapses very quickly. In fact, most people don't relapse very quickly. So most people who are going to relapse will tend to relapse after a year, 2, 3, sometimes longer than that. And of course, during that period, they'll be having CT scans as part of their surveillance, and there isn't anything there. So by definition, those patients who relapse slightly later have got microscopic disease, and we know it's there because they relapse later. So I don't see any biological reason why those drugs shouldn't be helpful for that group of patients. Now, you do always need to balance risk of treatment versus benefit of treatment, and there will be a point on those curves where you would be treating patients who have, the majority of whom have got a high risk of never relapsing, and you wouldn't want to expose patients who've been cured with surgery to a risk of toxicity. So there will be a point where the arguments swing in favour of not treating, but certainly I think it's clinically it would be fair to say that the 12-week point is really arbitrary. And for patients who perhaps are within a year or so of treatment and have still got most of their risk ahead of them, I wouldn't have a problem treating somebody in that scenario if I'm allowed to.
So up to, would you have a point up to when it isn't?
I think the logical argument will depend upon the individual staging, because the kinetics of relapse differs between whether somebody's stage 3A or 3B or 3C. So I think that would be an individual conversation to have with your oncologist.
Okay, great. Thanks very much. Thanks.
Can you just stress, just to stress the point that
it won't be necessarily a discussion between you and your doctor because there will be
Can you have a mic?
Sorry, I'm a medical oncologist, and and Paul and I work together. I think it's just really important to stress that, as Paul said, that's what he thinks as his opinion should happen. But there are other commissioning issues that will dictate. So you can just be very careful that actually these are areas, because there is the evidence base is within patients who started treatment within 12 weeks of their surgery. And although you can make the case, it's difficult. You have to bear in mind that it may not be an option for you.
Yeah, so I mean, as I started off, I said, I think two things: what I think will happen and what should happen. In the same way as my attitude to retreatment at the moment. That's a situation, we're employed, all of us here, the clinicians are employed by the NHS, that's the organisation, they make the rules, and as an employee, you have to follow those rules, and that's the reality of it. But I will still let you know what my opinion is about how I think the disease should best be managed.
And Imogen, just one more question.
Okay.
Because of lunch.
Dr. Nathan, you mentioned that the...
That's the first time Kay has ever called me Dr.
Paul,
Nathan, I have to say. So.
Paul, you mentioned that the complete lymph node dissection had an effect on overall survival, but what about relapse survival? Because there's going to be a gap now between when patients can get this adjuvant therapy, and they might make a decision that they still want to go ahead and do that as an option if they can't get the drug treatments.
Okay, so yes, so completion lymphadenectomy has no benefit in terms of overall survival. Because of the nature of melanoma, when it relapses, the most common place for it to relapse is in the local lymph nodes, and then it moves on to other places. So if you remove those lymph nodes, you've removed the place where it will first relapse, and therefore the time before relapse is going to be later because you have to wait for the disease to pop up somewhere else than if those lymph nodes are intact. So basically you're just removing the first place that becomes visible, and therefore it takes longer for the disease to become visible somewhere else. So that's why you'll have a delay in relapse-free survival in patients who've had a completion lymphadenectomy. But it doesn't mean that they benefit from that at all. They're still in the same situation. They've just had an operation that's made their legs swell.
Thank you very much, Dr. Paul Nathan.